All right, let's get started. We have to finish lecture 23. And remember, we had been talking about transfusion reactions, both acute and, which means they happen within 24 hours of the transfusion, and delayed, meaning that the symptoms don't appear until 24 hours after treatment. But remember, most commonly, if you've had a hemolytic delayed transfusion reaction, those symptoms won't appear until about 5 to 7 days, but can even appear later than that as well, okay? All right, so what you guys need to know, what you're going to encounter in the lab, the first thing is the nursing staff's going to call you and say, my patient has developed symptoms. You need to know what type of symptoms, okay? That helps us to know what kind of transfusion reaction to suspect. Did the fever spike? Then we might suspect a hemolytic febrile transfusion reaction. Such would be if it's the wrong ABO. If there was a fever involved, it could be a febrile non-hemolytic transfusion reaction, which would we suspect HLA antibodies and or bacterial contamination, okay? If your patient has just developed hives and is complaining of itching, then that is symptomatic of an allergic reaction. You can tell the nurse to give Benadryl and then resume the transfusion. If they think it's a severe allergic reaction, that might be an anaphylactic reaction, then of course immediately stop the transfusion and send to blood bank for workup, maybe suspect an IgA deficiency, all right? I mean, remember what happens in a delayed transfusion reaction. What you're going to see is the patient already has an established antibody, but it drops down to undetectable levels. So blood bank might not be able to detect it in our antibody screen. And then if that patient is transfused an antigen positive unit, then that titer is going to jump up and that antibody is going to attack the donor cells, resulting in symptoms of anemia in the recipient. Okay, and they'll usually present about 7-10 days later, maybe, all right? All right, so the first thing you need to tell the nurse is stop the transfusion, ask what type of symptoms your patient's having, tell them to, they can remove the unit, but maintain IV access. Depending on what type of reaction occurs, they might need to give that patient fluids, depending on how severe it is. Maybe if it's an anaphylactic reaction, they need to give epinephrine or another steroid. So maintain that IV access. Vital checks are very important. So they'll definitely have the patient's blood pressure, temperature, all of that. They will have been monitoring that every 30 minutes. If blood bank and the clinicians decide to do a transfusion reaction workup, part of that workup, they must send the unit back to blood bank, okay? It's part of our clerical check is to check that unit, confirm the type of that unit. They also need to send another blood bank sample, post-transfusion sample, that's what we call it in blood bank. That is what we will do our transfusion reaction workup on. We're also going to pull that pre-transfusion sample as well. All right, whatever the original cross match was performed on, we're going to repeat testing on that as well. If we suspect it's a hemolytic transfusion reaction, they will need to send a urine to the clin lab as well. All right, and that's just to check for hemoglobin urea. All right, if a hemolytic reaction is going, there will be some hemolysis going on. We'll be able to detect that in the urine as well. So the first thing when you receive that post-transfusion sample, you're going to spin it down, separate the red cells from the plasma. We want to visually look for any hemolysis, okay? And if you have hemolysis, it could indicate that it was indeed a hemolytic transfusion reaction, okay? We're also going to do your clerical check, pull that pre-sample, confirm patient identification, make sure it matches your post sample, all right? Your name, your medical record number, date of birth, everything matches. And then you also check the unit. Make sure your unit was ABO compatible, repeat any cross matches, and make sure everything was good to go. We're also going to do a DAT on that post sample, just to see whatever's causing the hemolytic transfusion reaction will be attached to the red cells, all right? And so that's how we will be able to tell. If an intravascular hemolytic transfusion reaction is suspected, we want to make sure and check the renal status of your patient. Remember, because if it's a intravascular hemolytic transfusion reaction, those red cells are being hemolyzed very rapidly, very quickly. You could have some red cell stroma, like cell fragments, and they can get sequestered in the kidney, all right? And that could cause kidney damage. Coagulation status too, all of those cell fragments can initiate the coagulation system. Part of a hemolytic transfusion reaction is the patient could go into DIC. And then signs of hemolysis, the LDH, your bilirubin, will be increased if intravascular hemolysis is occurring, and your haptoglobin will be decreased. If you receive the sample from BloodBank or from your patient post-transfusion, there's no visible hemolysis, your DAT is negative, but your patient spiked a fever, all right, so then we would suspect a febrile non-hemolytic transfusion reaction. We might suspect bacterial contamination. So anytime really your patient spikes a fever, it's a really good rule of thumb. BloodBank's going to forward that unit to micro for culture. Right? We just want to make sure that it wasn't contamination that caused that patient to spike a fever. We will send the unit to micro, and then also if sepsis is suspected, then they might also draw some blood cultures on the patient as well. All right, so this flow chart just really demonstrates what happens in a intravascular hemolysis situation. It really just breaks it down. So you have an antigen antibody complex. So if it was ABO incompatible, this would be your IgM ABO antibodies attaching to the red cells. That's going to activate complement, will activate your mast cells. Serotonin and histamines are going to be released. Also, cell lysis is going to occur. So you'll have hemoglobin, which could be released into the urine. Your endothelial cells are going to be damaged. Tissue thromboplastin is going to be released, activating the coagulation system. And then your patient could go into DIC. And then also, it could ultimately go into renal failure as well. So this is how serious intravascular hemolysis is, okay? Typically, you will see this for the wrong ABO. So Sarah asked if a sepsis can cause a drop in hemoglobin in hematocrit. There is the possibility that some bacteria can cause cell lysis. And if that's the case, then your hemoglobin in hematocrit might drop. That could also result in some intravascular hemolysis. It will not be as severe as the wrong ABO given, all right? So it depends on what type of bacteria and the mechanism of that bacteria. That's why coordinating with micro is very important too. They need to get that gram stain as soon as possible. All right, so here's some adverse reactions of a transfusion that we have talked about, all right? Acute hemolytic transfusion reaction, okay, that would be the wrong ABO type given. Delayed hemolytic transfusion reaction. We talked about allergic and anaphylactic reactions. We talked about febrile non-hemolytic transfusion reactions. Remember, in febrile non-hemolytic transfusion reactions, the culprit with that is usually HLA antibodies, okay? And leukoreduced products has decreased the adverse effects of HLA antibodies. Bacterial contamination, we talked about trolley. We also talked about taco. And then we also talked about graft versus host disease. All right, let's briefly summarize what our expected DAT results would be in each of these cases. So for an acute hemolytic transfusion reaction, do you guys think you'll have a positive DAT? This would be like if you were given the wrong ABO. Yes, you would probably have a positive DAT depending on the timing of that specimen and how fast cell hemolysis is occurring, all right? But more than likely, you'll have a positive DAT. You could also have a dual population of cells. So if your patient is type O and they were given type A cells in our post-transfusion sample, we would be able to get some mixed field agglutination and pick up both of those cell populations. A delayed hemolytic transfusion reaction, such as the kid family is heavily susceptible for a delayed transfusion reaction. Do you think your DAT would be positive in that post sample in that situation? So think about what's happening there. The original antibody titer drops to undetectable levels. The patient is transfused an antigen positive unit. That antibody titer is going to jump up and now is attacking the donor cells. Your DAT will be positive, all right? And your key word there, hemolytic, all right? Now, your acute hemolytic transfusion is usually going to be occurring intravascular. It's more serious. Your delayed hemolytic transfusion is just an IgG that is attached to those red cells being taken out by the RES system, right? So it's more extravascular. That's why the symptoms are not as severe, okay? What about in allergic and anaphylactic reactions? Do you expect your DAT to be positive in those? No, all right? That is just activation of your mast cells. Histamines are being released, all right, if it's a mild allergic reaction. And then in anaphylactic, those symptoms are more severe. It could ultimately block the airway that we talked about, okay? So anaphylactics are more severe. You would suspect anaphylactic reactions if your patient is IgA deficient, okay? Immune modulation or alloimmunization, all right? So the more patients are transfused, the more likely they are to be alloimmunized, meaning that they will build an antibody. Viruses exposure, our next lecture is going to talk about all the testing of all the viruses that are currently being performed on donors to try to prevent the transmission of virus. It's actually documented, I read, that you are more likely to, oh, never mind, I don't want to say that. Well, it's okay. So you have the risk of receiving the wrong ABO, right, which is a severe risk of a transfusion, or you have the risk of receiving a virus. So with the testing now for all the viral infectious disease that is done on our units, you're more likely to get the wrong ABO than you are to receive a virus. Does that make sense? So because the testing is so rigorous and now it's all done by nucleic acid, and our window of detection has really decreased as well. So, but there's still that window. So there still is a risk. Hepatitis B, hepatitis C, HIV still has like a 7 to 9 day window where the patient could have been exposed and our testing will not detect it, okay? And then parasites, we'll talk about in the next lecture too. Creutzfeldt-Jakob, you guys know, is a central nervous system disorder, really associated in the United Kingdom area over there. That's one of the reasons for the question on your donor questionnaire. Ask if you have traveled to any of the European countries or if you have lived there, really back in the 80s and 90s, all right? So that's the concern. And Creutzfeldt-Jakob transmission is associated if you ever receive any pituitary derived transplants or anything like that, okay? So that's the concern with Creutzfeldt-Jakob. Mad cow disease, if you guys aren't familiar with Creutzfeldt-Jakob, that's the mad cow disease. And then we talked about some other side effects, hypothermia, citrate toxicity, circulatory overload, which is TACO, iron overload, hyperkalemia, and then also bleeding, okay? So there's actually a lot of quality assurance methods in order to prevent these reactions, like I've already mentioned. Number one, that donor questionnaire, okay? So donor selection, not only the questionnaire, but the physical examination of the donor as well. More sensitive viral testing, like I mentioned. If you were to receive, say your patient has hemophilia A, which is the factor VIII deficiency, used to, FFP was our only option to give them as therapy. However, now we have recombinant DNA factor VIII concentrate, which can be virally inactivated. So it's a lot safer product, and it usually comes in a vial, and then patients can give themselves injections at home. So it reduces the amount of time the patient has to come to their physician. Strict patient identification procedures, both on the donor side and on the recipient identification as well. Maintaining your unit storage and collection process. Barcodes. Everything now on the hospital side is barcoded. Your units are barcoded. Patient identification is barcoded. So that has really helped reduce the amount of clerical errors. Special wristbands, again, that's your patient ID. Computer cross matches. Computers have helped as well, because you load your inventory, your blood product inventory, into your system, and then the system knows, based on your patient ABO, if those units are compatible or not. And there's a lot of safety checks that are built in. And if there's anything that doesn't match, the computer will stop you and not let you issue that unit, okay? Transfusion committees. Every blood bank will have a transfusion committee. So you guys, if you're working in blood bank, you might get to serve on the transfusion committee. The transfusion committee, what they do, they establish all the guidelines for that specific blood bank, and then they will investigate all transfusion reactions, what caused it, how can we prevent it from happening again, okay? Blood bank, I've mentioned this before, is actually one of the most heavily regulated departments of the lab. So it's regulated by FDA, CAP, as well as the American Association of Blood Bank, the AABB, has established guidelines as well. And then the Healthcare Finance and Administration, which is an old language, now known as CMS, Center for Medicaid and Medicare Services, okay? Continuing education of your personnel, competency assessment. You guys, once you're initially hired, you will have to do a 90-day competency. So you'll have a 90-day training where you do your initial competencies. And then after that, you will have yearly competencies that everybody has to do to maintain your documentation of your skills. Okay. And then reagent and equipment check. We will talk about all of that in a future lecture too, all of the quality control, quality assurance, preventative maintenance, and all of that. Don't forget, quality assurance also includes your visible inspection of the unit. We talked about some microclots that might appear, turbidity, any type of precipitate clotty material that could be indicated of a contamination. Say if that unit's not safe for transfusion. And I cannot stress this enough. Error reporting. If you realize you make an error, be open about it. Go through the correct process of identifying the error and then correcting the results, right? So if you actually entered the ABO on a wrong patient, be open about that, do your corrective report, and then make sure it's corrected in the computer. Now, everybody's going to be able to see that, so that initial result that was released will be in that patient's chart, but it'll be very blatantly identified as a incorrect result, and then the correct result will be as well. Okay, so don't try to hide any errors. Okay, it's very important that you be very upfront about errors. Okay, it happens. All right, just don't try to hide it. Some alternatives to transfusion. So we had talked about before, maybe your patient's symptoms, maybe a product is not the best option for them. There are other options, such as maybe your patient needs a little bit more oxygen. Rather than giving them a red cell transfusion, maybe just hooking them up to the nasal cannula to deliver oxygen might be a better therapy for them rather than exposing them to a donor unit. A lot of hospitals have implemented new restrictions for transfusion. They usually have a hemoglobin level threshold. So if your patient is not at, like UAMS's was 8 grams per deciliter. So if your patient was above that 8 grams, then they did not qualify for a red cell transfusion. All right, your facility might even, I've seen it as low as 6 grams. So depending on, so those guidelines have been established for blood product management, to reduce the number of transfusions and to conserve our blood products. Because donors are a huge concern as well. And especially, I don't know if you guys have noticed, don't be surprised if you don't see an announcement from collection facilities. With the outbreak of coronavirus, a lot of people are getting panicked, and the donor collection facilities are saying people are canceling their appointments to donate. So don't be surprised if we go into a blood product shortage, all right, because of this outbreak of coronavirus. I saw that this morning. So.
How regularly would that sort of thing occur, blood product shortage?
So we usually have, there are different times throughout the year where we go through blood product shortages. The summer is a really heavy time where blood product shortages. Now you asked me why in the summer. I don't know if it's because people will take vacations during the summer. High school students actually surprisingly are a huge donor pool. And so they're out of school during the summer. So maybe they get off of their donation cycle. So the summertime, we usually go through a blood product shortage. Anytime there's like a natural disaster, usually people will want to donate around that natural disaster because they want to do their civic duty and help. So typically donations will go up after that, around that time. During the summer is the #1 thing that I think we have seen a blood product shortage from my experience. I was trying to think when the Ebola scare came around, if I remember any blood product shortage like we've seen now with the coronavirus, but I don't know off the top of my head. There's other agents too, so maybe if your patient has symptoms of anemia, maybe give them erythropoietin to stimulate the bone marrow to produce more red cells. That would be another treatment rather than a transfusion. Single donor components, that's like platelet pheresis, plasma pheresis, that is more product for your buck, all right, from one single donor rather than pooling a bunch of products together from multiple donors, all right? That has significantly helped the transfusion process too. And then the #1 safest transfusion, autologous, okay? And we're also gonna talk about cell savers. So if you guys are scheduled for surgery, especially a surgery that could involve high blood loss, such as a vascular surgery, then you could do cell saver. And so cell saver involves suction during the procedure, and all the blood that is lost gets washed and returned back to you. So you receive your own blood back. That reduces the exposure to donor units as well. Cord cells and gene therapy have really been instrumental in like those patients that have been diagnosed with cancer or another rare disorder, rather than transfusing, giving them stem cells to try to stimulate cell production again. And here's some autologous donations that we will talk about in a future lecture. Pre-operative, where if you know you're scheduled for surgery, usually about 4 weeks out, you can go and donate. You can do an autologous donation. You can have family members donate for you. That would be a directed unit. Hemodilution is where prior to the surgery, they will remove some blood and then they will give you fluids for volume replacement on that. And then they save that blood to be transfused during the surgery. Intraoperative salvage, that's the cell saver that I was mentioned, and then post-operative salvage. And then stem cells. So a lot of our cancer patients do autologous stem cell donations. And they do that here at UAMS a lot. I think it's in our very last lecture of this course, we will talk about blood substitutes, specifically the production of synthetic blood. It is not currently being used, but there is research undergoing for synthetic blood. And so in our last lecture, we will talk about that. So blood substitutes. Synthetic volume expanders, and then new preparations, solvent or detergent. This is actually what's being used in the Factor VIII concentrate where they are inactivating all of the DNA so it doesn't have any risk of transmitting viral diseases. However, there is not a current treatment using solvents or detergents to remove the viruses completely from red cells and platelets and plasma. They haven't got that far yet. All right, so that completes our lecture series on transfusion reactions, adverse effects of transfusions. All right, anybody have any questions?